The purpose of this evidence-based project is to determine how effective a checklist or bundle approach of insertion of an indwelling urinary catheter in continuing care of the patient affects the rate of a urinary tract infection from occurring. The incidence of catheter-associated urinary tract infections acquired in hospitals is incredibly high. 1 in 25 patients that are hospitalized will acquire a CAUTI in the United States. CAUTI can lead to further health complications, mortality, and increased healthcare costs.
Among post-surgical patients with indwelling urinary catheters, how does the use of an insertion checklist compared to no checklist impact CAUTI rates over a 6-month period? Improvement is needed. Catheter-associated urinary tract infections, otherwise known as CAUTIs, is among the most common infection acquired by hospitalized patients. More than 75% of urinary tract infections are associated with indwelling urinary catheters. Urinary catheters are not always removed as soon as possible post-surgery. Proper protocol for insertion is not always adhered to. Some nurses find it easier to take care of patients with catheters rather than getting them out of bed to use the toilet or risking injury to the patient if they try and get up to use the toilet without assistance. Who is impacted by CAUTI? Any patient that has a urinary catheter is susceptible to bacteria entering their urinary tract via the urinary catheter. People with compromised immune systems and the elderly population are more susceptible. Contracting a CAUTI can cause a post-surgical patient to have an extended stay in the hospital due to extra interventions needed to treat the infection. Hospitals are also impacted financially because they may not be reimbursed by insurance companies for treatment of this hospital-acquired infection. Reports will also reveal to the public if a particular hospital has a high rate of CAUTI. This could damage the reputation of the healthcare facility. To help combat the issue of CAUTI, the bundle approach has been used by many healthcare facilities. The purpose is to ensure timely removal of urinary catheters and insertion of catheters only when indicated. This is an example of an ABCDE bundle checklist for CAUTI prevention. A is for adherence to general infection control principles. B is for bladder ultrasound use protocol put in place to avoid unnecessary catheterizations. C is for catheter alternatives. D is do not use the Foley catheter unless medically appropriate. No appropriate indications for use. E is early removal of the catheter using a reminder or nurse-initiated removal protocol. Over the years, there have been many studies on the topic of CAUTI, many of them focusing on the use of a bundle approach. One study asked, how do healthcare providers perceive and assess risk? They also asked, how do these perceptions and assessments impact healthcare providers' decisions in relation to a patient safety initiative? Another study indicated that more nurses had knowledge of the CAUTI bundle approach than did not have knowledge. However, the nurses interviewed indicated that the number of units using the approach was lower than the number of units not using it. This is an example from research study article Evaluation of the Utilization of Catheter-Associated Urinary Tract Infection Bundles Among Critical Care Nurses at the Kenyatta National Hospital. The nurses interviewed were asked about their knowledge of the CAUTI bundle itself. 55.8% of nurses interviewed were aware of what the CAUTI bundle was, where 44.2% were not aware. 48.4% of nurses were aware of the elements of the CAUTI bundle, where 51.6% were not aware of the elements of the bundle. 45.3% of nurses said that their unit does utilize a CAUTI prevention care bundle. 54.7% said that their unit did not. 18.9% of nurses said that they were audited on the utilization of the CAUTI bundle, where 81.1% were not audited.
Catholic Health's aim for CAUTI prevention includes hand hygiene, Foley insertion using aseptic technique, appropriate use of a Foley catheter, routine peri-care, excellent care and maintenance of the Foley, and prompt removal of the Foley catheter when no longer indicated. Here we have an example of Roswell Park's CAUTI bundle. They start off with the development of a prompt in the EMR to alert physicians to the presence of Foley catheters and to determine and document the clinical need for the Foley catheter. They redesign of the nursing flow sheets to capture accurate data on catheter use. Creation and implementation of an algorithm to determine what a nurse should do after a urinary catheter is discontinued. A team review of any identified CAUTI cases. Standard catheter brand is used. Introduction of updated policies. They educate the staff, i.e. the nurses, about the CAUTI bundle, the algorithm, and the bladder scanner usage. Launching a CAUTI prevention website with links to pages about all aspects of the CAUTI bundle. They purchase new bladder scanners and changes to catheter inventory on all units.
Study number 1. The question that the researchers posed was, is a urinary catheter bundle with computerized documentation and ordering templates effective in reducing the use and duration of indwelling urinary catheterization in acute hospitalized patients? The research design was not stated in the article, however it can be assumed that the design method was experimental because the research study was examining the cause and effect of catheter-associated UTIs. The target population of this study were patients with an indwelling catheter of less than 30 days. With the collection of statistical data regarding the use of catheter devices, strategies were devised to prevent CAUTI. The researchers found that proper documentation and the removal of catheters can provide consistent care and reduce the occurrence of CAUTI in patients. Study number 2. The purpose of the study is to explore the actions of nurse leaders that facilitated clinical nurses' active involvement in emergency department catheter-associated urinary tract infection prevention programs. Researchers used the case study design method to analyze the perceptions of nurse leaders in their attempts to decrease catheter-associated UTIs. The target population of the study are nurse leaders, such as directors of nursing or managers who are responsible for clinical nurses in an emergency room setting. Clinical nurses are usually responsible for the initial insertion of a urinary catheter, therefore nurse leaders need to ensure that clinical nurses are properly trained and educated. Nurse leaders can enhance the knowledge of clinical nurses by promoting education and other opportunities in the workplace for prevention of catheter-associated urinary tract infections. The researchers found that nurse leaders may educate clinical nurses on the harm of urinary catheters to improve future patient outcomes.
Study number 3. Can a multi-component initiative focusing on technical and socio-adaptive interventions reduce catheter-associated urinary tract infections in nursing homes? This is a quantitative design. The target population includes residents in nursing homes with indwelling urinary catheters. 568 nursing homes across the U.S., including Washington, D.C., and Puerto Rico, that participated in the Agency for Healthcare Research and Quality Safety Program for long-term care were included in the study. Data was collected over the course of 30 months in 12-month cohorts. What this study found was that CAUTI rates decreased by 54% over the 12-month period. Of the facilities, 75% of them showed a decrease in CAUTI rates of 40% or more. Urine cultures were ordered less frequently. At the beginning of the study, the number of urine cultures were 3.49 urine cultures per 1,000 resident days. This decreased to 3.08 urine cultures per 1,000 resident days by the end of the study. Overall, the findings concluded that the technical and socio-adaptive interventions lowered CAUTI rates in environments where indwelling catheter use was expected to be prolonged in its patients and residents. Here we can see that as the program went on and the interventions were put into place, the number of CAUTIs decreased. Study number 4. Will new interventions implemented in the ICU and SDU, which is the step-down unit, result in decrease in CAUTI rates? The research design is a quasi-experimental study. The target population includes any patient with an indwelling urinary catheter that was in the private hospital in Brazil. Specifically, that patient must have been on one of the 2 medical surgical ICU floors, including 48 beds, or one of the 3 step-down units that had 95 beds. The study was conducted over the course of 9 years and was broken up into 3 phases. What this study found was that CAUTI rates in the ICUs fell from 7.0 to 0.9 infections per 1,000 catheter days by the end of phase 3. CAUTI rates in the step-down unit decreased from 14.9 to 1.0 infections per 1,000 catheter days. These results show that it is possible to reduce CAUTI rates, if not eliminate them, but in order to do so, the hospital staff needs to work as a team to make sure that the rates do in fact remain low. This figure right here shows the incidence density of CAUTIs per 1,000 catheter days in the ICU and SDU. It is shown for each phase of the study, 1 through 3, and you can see that there is a decline in CAUTIs.
Synthesis Study 5 used the article titled Physician-Initiated Daily Verbal Reminders Decrease the Duration of Indwelling Urinary Catheter Use compared with Nurse-Initiated Reminders. The research question for this study was, can nurse-initiated reminders to remove catheters be improved with physician involvement? This was a quantitative study performed at 2 New York City hospitals. The population for this study was catheterized patients that did not have clinically appropriate indications documented for catheter use. Patients that were in the intensive care unit were excluded from the study. This was a short study which they performed over a month time period from May to June of 2014. There were 54 total participants in the study. 11 were assigned to the control group, 21 to the nurse-initiated reminder group, and 22 to the physician-initiated reminder group. The study did show that with the physician-initiated reminders, catheter duration was significantly reduced. This graph shows a comparison of the 3 different groups in this study and the mean duration of catheter use. The blue is the control group that had no intervention, and they had a duration of 2.67 days. The nurse-initiated reminder group, which is in pink, did show improvement with a duration of 1.67 days, and the physician-initiated reminder group had the best results at a catheter duration of just 0.545 days. This study shows that it's important for all members of the healthcare team to be involved in the evaluation and assessment as to whether catheters are clinically appropriate or not. Synthesis Study 6 used the article titled Introducing the No Preventable Harms Campaign, creating the safest healthcare system in the world, starting with catheter-associated urinary tract infection prevention. While overall the No Harms campaign was looking to provide guidance and infection control to those that work in larger healthcare systems, they're also looking to implement practices to prevent infection. The initial problem that they decided to address was the catheter-associated UTIs, and that's what this study focused on. It was a mixed methods study with the qualitative part of the study being focused on any barriers that the staff came up against when they implemented their interventions. The quantitative part of the study focused on the rate of CAUTI. The population was veteran patients within the VA healthcare system that were located in the Veterans Integrated Services Network. In this study, they used a two-tiered approach. The first tier focused on using standardized catheterization kits and also daily monitoring for continued use of catheters. Tier 2 was implemented if a facility did not fall under the threshold rate for CAUTIs within a 6-month period. If consistently for 6 months they were over the designated threshold, then they would go to Tier 2, which involved assessment and documentation of competency of the staff, and it also involved root cause analysis for each CAUTI incident. The study did show that in the non-intensive setting there was a significant decrease in CAUTI, no significant change in the intensive setting, and it also showed in the qualitative portion of the study that effective communication is really important when developing new initiatives and implementing them. These graphs here show the CAUTI incidence, and this is over a 4-year period within the VA healthcare system. And it does show there's a box surrounding where they implemented their initiatives. The red is the non-ICU patients, and the blue is the patients that are in the intensive setting. There was a significant decrease, as you can see, with the non-ICU setting. Although that doesn't seem to be, well, there was a spike there in Q1 of 2013, it doesn't seem to be that there was a very significant change in the incidence of CAUTI within the intensive setting. And when we were looking at the previous slides, it didn't show that there was a real significant change in the intensive setting. But looking at this comparative with that it has both the intensive and the non-intensive settings, there was a huge decline in the intensive setting. This only just shows, though, from the initiation of the interventions on. But as you can see, there were initially 5 CAUTIs per 1,000 catheter days at the start of the initiative. And then in July of 2013, it significantly decreased and fell below the target range. In the non-intensive setting, they pretty well stayed below the target range for the entire initiative, except for, looks like, June of 2013. So it does seem to be that this initiative helped in the utilization of a standardized catheter kit, along with daily monitoring of the use of the catheters and whether they're appropriate or not, plays a big role in reducing CAUTI.
The use of a quantitative design method would allow for numerical data to be collected and then quantify the results to determine if the use of a bundled checklist has been effective for reducing the rates of catheter-associated UTIs.
So the proposed change is using a checklist or a bundle approach for catheter use. This involves a checklist for catheter insertion, typically the use of a standardized catheter kit throughout the facility, and then daily monitoring of the appropriateness of the catheter use. Also, a team should be implemented to oversee the utilization of the checklist and implementing these changes.
The target population of the study are patients who are admitted to a post-surgical unit in a hospital setting who have had a urinary catheter inserted. The population would be determined by the patient's admit date to the hospital and when the catheter was initially inserted. The CAUTI bundle approach needs to be enforced by nurse leaders on a post-surgical floor. Nurses need to be educated and trained regularly to ensure they are informed of the most up-to-date, effective practices. In order for this to occur, there needs to be a system in place that can enforce this idea. Leaders, managers, administrators, etc. can train staff at regular intervals, such as quarterly in-services, to provide information on CAUTI. These in-services can include paper handouts with the bundle approach listed and demonstrations of proper insertion and assessment techniques for quick removal of the device.
To implement this evidence-based practice, we would need to develop a checklist or bundle approach to use for urinary catheterization. Find team members that would be able to implement and oversee the use of the bundle approach. Educate and train staff in the use of our new approach or checklist. And also, it's important to reinforce appropriate catheter placement, use of aseptic technique, and using sterile supplies, evaluating the necessity of the catheter, and also importance lies in catheter care techniques. That's like the daily hygiene care of the catheter. Other parts of implementation include determining patients that do have a catheter present, selecting participants for the study, gaining consent from those participants. Then we would also need to randomly assign them either to a control or an intervention group, and then gather the data after our 6-month time period.
The stakeholders involved in catheter-associated urinary tract infections are hospitals and the catheterized patients. In 2008, Medicare ceased payment for treatment of many hospital-acquired infections, including CAUTI. Payment for the treatment of CAUTIs became the hospital's responsibility, which resulted in a decrease of these types of infections.
For evaluation, we would need to compare the CAUTI data, the data received from the control group and then the intervention group. We would also need to analyze the data, and that for quantitative studies is the most popular software is the SPSS software. Then we would obviously determine if our intervention was successful. And I think it's important also to gather staff input and see what they thought of the implementation of these new interventions and if they had any suggestions for improvement.
CAUTI rate, which is one of the primary outcomes, is defined by the number of CAUTIs meeting the surveillance criteria divided by the number of catheter days and multiplied by 1,000. Urinary catheter utilization ratio is the secondary outcomes, is defined by the number of catheter days divided by the number of resident days multiplied by 100. This is reported as percentage. Data would be collected on a daily number of CAUTIs, catheter days, and resident days for each month of the project period. Projected outcomes include increased utilization of CAUTI checklists or bundles, decreases in CAUTI rates, decreases in catheter utilization, a decrease in catheter days, and the formation of CAUTI Prevention Task Force.
For integration, we would need to develop a policy for continued use and a policy that people could go back to and refer to if they had any questions. And again, encourage staff input. We would need to continually evaluate the checklist to see if there is a need to make any changes and make sure it's keeping up with current standards of practice. And then continue to monitor the incidence of CAUTI and make sure that that is being kept under control. Maintenance of this evidence-based practice would definitely include continued staff education. We could do that with lunch and learns, monthly in-services, yearly in-services, any way to keep staff engaged and keep them educated and up to date as to what we're doing to prevent catheter-associated urinary tract infections and make sure that they're following the policies. It would be important as well to evaluate staff competence and proficiency possibly doing this annually with having staff demonstrate the different areas that they are involved with catheters and make sure that they're doing the care properly, insertion properly, and things like that. We could incorporate the policy into the new employee orientation. That way new staff are being familiar with the policy right off the bat. And then also patient education and teaching patients how to properly care for their catheters as well. Providing positive reinforcement to the staff is also important in the maintenance. If you see staff doing a good job, commending them on that if they're following the policies and protocols on a consistent basis. Providing feedback to the administration and let them know how things are going with the implementation of the new policies. Let them know if there's been improvement in the CAUTI rates and where the CAUTI rates continue to lie. Again, continued evaluation of the policy. There's always room for improvement. And then providing data to the staff. This allows them to see that what they're doing actually makes a change. And this just doesn't include the RNs or the providers, but as well as the unlicensed assistive personnel that are doing the daily catheter care.